Okay, we're broadcasting.
Good morning, everyone. Welcome to our third Global Health Compassion Rounds. We will be waiting a few moments while the attendees join us. We'll begin in another minute or so. Welcome to our third Global Health Compassion Rounds, co-hosted by the Focus Area for Compassion and Ethics, or FACE, at the Task Force for Global Health, and by the Global Learning Laboratory for Quality Universal Health Coverage at the World Health Organization. The Global Health Compassion Rounds are intended to serve as a platform for a growing community of practitioners and people interested in the field of compassion and global health. It's intended both to inspire and encourage us, but also to challenge us. We're very pleased that you've joined us today. My name is David Addis. I'm the Director of the Focus Area for Compassion and Ethics at the Task Force for Global Health. Today we'll be exploring the question, is compassion essential for quality healthcare? What does it add, if anything? And our keynote speaker to address this question is Dr. Stephen Trzeciak, a scientist clinician specializing in intensive care medicine at Cooper University Healthcare in Camden, New Jersey, and co-author of the best-selling book, Compassionomics. After Dr. Trzeciak speaks, we'll have reflections from three different people from different aspects of healthcare in the world, particularly at the national level, district level, and then the local or facility level. Dr. Andrew Lakaka is the Director of Quality Management and Digital Health at the Ministry of Health and Population in Malawi. And he'll be speaking about the national level. Welcome, Dr. Lakaka. Dr. Louis Ako Egbe is the Director of Quality Management and is a District Health Manager in the Southwest region of Cameroon with a great deal of experience in district health management and quality care, and he'll be speaking from his perspective. And then we also have Ms. Samia Abdullah, who's a community engagement consultant based in Clarkston, Georgia. And we will be introducing all of our speakers in a little bit more detail before they speak. A few housekeeping details. Other than the speakers, the microphones will be muted. If you are a speaker, Ashley, who's here with me, will be unmuting your microphones just as you're scheduled to speak. We will have time for questions. We encourage all of you to use the chat feature on the Zoom and to post your comments, questions, critiques, and we hope to come to at least some of them by the end of our time together today. At this point, I'd like to turn it over to our co-host, Dr. Shams Syed at the World Health Organization, to frame up our conversation today in the context of quality health services. Shams?
Thank you very much, David. Really very excited to be with you all for this Global Health Compassion Rounds. For us, this exploration continues today. We're examining, as David has nicely laid out, the linkages between quality and compassion. And as many of the colleagues on this call will know, each of the quality elements that have been described over the last decades has linkages with compassion. But of course, those linkages mean nothing unless it affects positively human lives where services are being provided. And that's particularly why it is so exciting to see this Global Health Compassion Round explore some of the evidence and experience from the work that Trzeciak has done, and importantly, to look at what the ramifications and implications of that work is at the national level, at the subnational level, and at the point of care and in the community. We do believe that there is a need for a fundamental shift in how services are delivered across the world to place compassion right at the heart of reform of health services. And each of the quality elements, whether that be effectiveness, whether that be safety, whether that be people-centeredness, has really quite important linkages to compassion. But other quality elements, such as timeliness, equity, integration, and efficiency, also have very strong linkages to compassion. I'm sure a lot of the information that you'll be hearing from Dr. Trzeciak will inform us in that discussion. But theoretical pieces mean something only, and just to reiterate, when it has an impact on lives. And this is where the quality element, the quality dimension of our thinking really needs to be strengthened. And when refinements are made to services across the world, placing this in the heart of some of the policy dialogue that I'm sure Dr. Likaka will be able to speak to, placing it within some of the district level organization reforms and changes that are required, I'm sure that Dr. Akwe will be able to speak to, and having some refinements to the facility level and community level engagements that I'm sure that Samia Abdullah will be able to speak to. So this is an opportunity to explore. We don't know all of the answers, but we do know some of them. And this is where the Global Health Compassion Rounds hopefully can stimulate us in making the necessary refinements in our own thinking so that necessary action that is required can take place. So I'm really looking forward to this, and I'm looking forward to the discussion particularly that also unfolds through this Compassion Rounds. Thank you, David. Back to you.
Thank you very much, Shams. It's my pleasure to then move to introduce our keynote speaker, Dr. Stephen Trzeciak, who's a physician scientist and chief of medicine at Cooper University Healthcare and chair of medicine at Cooper Medical School in Camden, New Jersey. Dr. Trzeciak's a specialist in intensive care medicine, so he's been very busy in the last 4 months. And he's also a medical researcher, a scientist. Somehow along the line, he got steered into studying the scientific effects of compassion on patients, patient care, and those who care for patients. And maybe he'll tell us a little bit about this detour in his career. This work has resulted in the best-selling book that Dr. Trzeciak co-authored. It's called Compassionomics. And it reviews the scientific evidence for compassion in healthcare, and you'll get a synopsis of some of what's in that book today. Steve, it's great to have you with us, and thanks so much for joining us, and we very much look forward to your presentation.
Thank you, David. So I want to start by thanking the task force, the focus area for compassionate ethics, the World Health Organization, Emory Universities. But personally, I want to thank David. I want to thank Shams and Ashley for the honor of being here with you to participate as a speaker in Global Compassion Rounds. It means a lot to me, and thank you. So as David mentioned, for the first 20 years or so of my life, I was a physician scientist practicing and doing research in a totally different area. I'm an intensivist, a specialist in intensive care medicine, and I study resuscitation science. And specifically, I was studying the effects of oxygen on the brain following cardiac arrest and trying to figure out the optimal oxygen level after cardiac arrest. And now I study compassion in healthcare. And that is a bit of a pivot for me. And the reason behind it broadly, and of course there are stories that we won't have time to get into today, but I became convicted of the fact that the most pressing problem of our time is an erosion of compassion. Now, I believe that to be true in society in general, in the world in general. I think that a lack of compassion underpins much of the problems that we're having in so many different domains. But is it also present in healthcare too? And what I want to do over the next 25 minutes or so is take you on a journey through some of the evidence that my colleague Anthony Mazzarelli and I uncovered in doing the research for the book Compassionomics. What we found in our journey through the evidence is that compassion can have powerful benefits for patients and for the giver too. A couple of statements I want to make from the outset, just for consideration before I get into my presentation today. Number one is I want to assure you that I don't have any sort of magical thinking about compassion. What I mean by that is that clearly the number one determinant of clinical outcome is clinical excellence. So I'll say that again. The number one determinant of clinical outcome is clinical excellence. If you are a surgeon who botches a procedure, or you're a physician who prescribes the wrong medication, there is no amount of compassion that is going to undo that. It's not an either or, however. When our book first was released, the Washington Post did a story about it, and in their social media, their tagline was, "Would you rather have a physician who graduated at the top of their med school class or was compassionate?" As if it's an either or. It's not. It's clinical excellence and compassion yield the best outcomes for our patients. And I just want that to be I want to be clear about that from the beginning. But don't take the false choice of an or. It's actually an and, clinical excellence and compassion. The other thing that I'd like to say is that you might be thinking that because I was invited to speak with you all today in Global Health Compassion Rounds that I must be the most compassionate doctor. But the truth is I'm just a work in progress. I'm a work in progress, very much so, but I see it now, and I'm working hard to get better at compassion every day. So I'd like to begin with a story that opened my eyes to a stark reality. On February 27, 2007, on a snow-covered stretch of highway outside of Uppsala, Sweden, two buses collided. Head on. This is what was left of one of the buses. You can imagine what the scene was like at the hospital. Tragically, 6 people died, but miraculously, 56 people were saved. Now, 5 years later, researchers asked the question, what do survivors remember? Using a rigorous qualitative research methodology, they've interviewed every survivor. And they found 2 common themes in the data. The first was very much expected. It was the physical pain, the pain that they felt at the moment of impact. But the other theme, it was a lack of compassion from the caregivers at the hospital. What becomes more striking about this study was when you realize the fact that they were taken to multiple different trauma centers, and they all had the same experience. These data open my eyes to a stark reality. I believe that in healthcare, we're in the midst of a compassion crisis. Now, you may say that we have a lack of compassion in society in the broad sense, or an erosion of compassion. And of course, I would agree, and there are abundant data to help support that. But healthcare is supposed to be different. So what's the evidence for a compassion crisis in healthcare? So I'll share with you some data from the US. A study published in the journal Health Affairs surveyed 800 patients as well as physicians and found that 50% of patients and healthcare providers in the US believe that our healthcare system and our healthcare providers are not compassionate. Similar survey data are available from Europe as well. Multiple research studies have found that physicians miss 60 to 90% of opportunities to respond to patients with compassion. And that compassion comprises typically just 0.5 to 1% of physician statements to patients in the context of a healthcare encounter. Recent data from the Mayo Clinic in the US show that the median time to interrupting a patient in an office visit when they're trying to state their main complaint, the main reason why they came to see the doctor, is 11 seconds. And with interruptions at 11 seconds, I think it's hard to see any sort of compassion connection with the patient. In my domain in critical care, a Johns Hopkins study found that 74% of interactions between ICU staff and patients or families in the ICU had an absence of compassion. In a particularly striking University of Washington study supported by the NIH, they found that in end-of-life conversations in the ICU environment, end of life, fully 1/3 of these meetings to have end-of-life discussions had no expressions of compassion from the healthcare team to the patient or the family. And in the era of burnout, a burnout epidemic, where depersonalization, which is an inability to make a personal connection, is found in more than 1/3 of healthcare workers in the US and nearly 1/3 in the UK, as expressed in a recent BMJ report, that have low compassion satisfaction, meaning low joy from taking care of patients and providing them with compassion. In the area of depersonalization and burnout, we have fewer meaningful connections with patients. So based on all of these data and more, I submit to you that we have a compassion crisis in healthcare. But here's a big question. Does it matter? Does compassion really matter? Now you may say, of course compassion matters. We have a moral imperative. We ought to treat all patients with compassion. It's a cornerstone of the art of medicine. Of course I agree. But is compassion just part of the art of medicine, or are there also evidence-based effects belonging in the science of medicine? And what is the evidence? Now, I'm a bit of a research nerd, and research nerds like methodology. So the methodology that I took to this question was systematic review. The hypothesis that Anthony Mazzarelli and I generated was that compassion matters for patients, for patient care and the quality of care, and those who care for patients, so our healthcare providers. So our hypothesis was that compassion matters not just in meaningful ways, but also in measurable ways. So we performed a systematic review. We had a 2-year journey through the evidence. We went through more than 1,000 scientific abstracts, more than 280 original science research papers. And today I share you some data on what we found. The effects of compassion on patients, on patient care, and those who care for patients. But of course, we have to make sure that we have the same nomenclature. Nomenclature matters. So what's the definition of compassion? Although there's been some debate about this in the scientific community, most researchers agree that compassion is the emotional response to another person's pain or suffering involving an authentic desire to help. Now, it's slightly different from a closely related word, empathy. Empathy is the feeling, the sensing, the detecting of another person's emotions, resonating with those emotions and understanding their perspective. Compassion is different in that it goes further. Compassion is taking action to relieve someone's pain or suffering in some way, in whatever way is possible. So empathy is feeling, compassion is action. We like to say empathy plus action equals compassion. And there are actually neuroscience underpinnings for this distinction. They're using functional MRI. Neuroscience researchers have found that if you have empathy, you witness another person's pain or suffering, a part of the brain that will light up that is associated with pain. It's a pain center of the brain. That's because it actually hurts. When you witness someone in pain or suffering, it's uncomfortable for you, it hurts. You also will experience pain. I feel your pain. There are neuroscience data to support that. But when someone takes action to alleviate someone's pain or suffering, another distinct neural structure lights up on functional MRI studies. It's an area of the brain that's associated with affiliation and positive affect, actually a reward center of the brain. So we like to say empathy hurts, but compassion heals. And we think that these distinctions, sensing, detecting, feeling, and action, are very important because from a patient's perspective, what they feel is the action that we take. So now I want to go into some data that to support why compassion matters for patients, or the ways in which compassion matters for patients. But we have to just take a broader context first, that relationships matter. The Harvard study of adult development found that the most powerful predictor of good health and longevity into your 80s isn't some biomarker. It's not your blood pressure, your hemoglobin A1C, or your cholesterol level. It's actually the quality of your relationships. Similarly, on the other side, we're well aware of the data that loneliness kills. Loneliness is associated with decreased longevity and adverse health effects. So if relationships matter for good health in the broad sense, could they also matter in our relationships with patients? And what we found is that there is an abundance of evidence that supports that compassion can be have powerful benefits for patients, for patient care, and for those who care for patients. Because compassion, healthcare with compassion is beneficial compared to healthcare without compassion, because a human connection can confer distinct and powerful benefits. So on this slide, I've shared with you some of the different domains for the clinical effects of compassion from the patient perspective. Physiological effects, psychological effects, effects on quality of care, and on patient self-care, how patients take care of themselves. Of the 280 original science papers that we cite in Compassionomics, more than 100 are on effects for patients. And of course, I can't review 100 different papers with you here. I'll just use some examples. First, starting with physiological effects, compassion for patients can modulate stress-mediated disease. It can reduce a patient's perception of pain. It can have immune system effects and endocrine system effects. One study, for example, in the domain of anesthesiology, two randomized controlled trials, one from Journal of American Medical Association and one published in the New England Journal of Medicine, found that compassion for patients with an extra visit from an anesthesiologist for building rapport and compassion and allaying someone's fears before they undergo surgery, which is one of the most vulnerable times of a patient's life. Extra compassion, what they called a special care visit from the anesthesiologist, was associated with a higher odds of achieving adequate sedation for surgery. This is when it was compared head-to-head with a powerful sedative, pentobarbital. What they found is patients who had a special care visit from the anesthesiologist and that rapport-building visit, they were calm, but they weren't drowsy. And in contrast, patients who received pentobarbital were drowsy, but they weren't calm. And in a follow-up study in the New England Journal of Medicine, they found that special care from the anesthesiologist was associated with decreased opiate pain medication requirement following surgery. Now, pain is one of the most complex aspects of all of medicine. It's so complex that there are entire fields of study devoted to it because of all the different components of a patient's experience of pain. But clearly shown in laboratory studies, meaning experimental studies, experimentally induced pain, that the touch of a trusted other can reduce a person's experience of pain. I said it can attenuate it. It doesn't eliminate it, because compassion, of course, doesn't eliminate pain, but it can attenuate one's experience of pain. And this has been shown in the laboratory. But what about clinical? More compassion from clinicians has been associated with lower experience of pain from patients in not only the postoperative realm, but also in patients with low back pain, which in the US is the #1 reason that people miss work. Also the abdominal pain associated with irritable bowel syndrome, Also the pain that migraine headache migraineurs experience, and that was studied in a migraine headache clinic. There are also immune system effects. So in a University of Wisconsin study supported by the NIH, they studied patients with a common cold in a primary care setting. And what they found was that an optimal compassion from the healthcare provider was associated with increased immune response in the patients, as evidenced by interleukins in their nasal washings, as well as 15% decrease in the duration and the severity of their cold symptoms. A study from Thomas Jefferson University, which is right across the river from me in Philadelphia, they found that in patients with diabetes, that compassion was associated, optimal compassion from clinicians was associated with 80% higher odds of optimal blood glucose control and 41% lower odds of acute complications of diabetes requiring admission to the hospital. Now let's go to psychological effects. And it may be intuitive to some extent that compassion is very important in one's psychological healing. But studies from the University of Pennsylvania, from Duke University, and the University of Colorado, supported by the NIH, have found that in patients with depression, compassion can have a moderate to large effect on the resolution of depression symptoms. Numerous studies have also found that compassion can decrease anxiety, and those that suffer from anxiety can also decrease the psychological distress that is associated with somatic disease, like people who are experiencing cancer. Self-care is a very important aspect of medicine. It's how patients take care of themselves when they're not in the healthcare environment, not with the healthcare providers. Numerous studies have shown that when you care deeply about patients and they feel that, they're more likely to take their medicine. For example, in a Johns Hopkins University study in 1,300 patients with HIV, they asked those patients, does your healthcare provider, your HIV provider, know you as a person? Knowing the patient as a person, after they adjusted for every factor that could be associated with non-adherence to HIV, antiretroviral medication, they found that knowing the patient as a person was associated with a 33% higher odds of adherence to antiretroviral therapy and a 20% lower odds, or 20% higher odds of having no detectable virus in the blood. So knowing the patient as a person, the patients had self-efficacy. They believed that their disease can be controlled. They had statistically significantly higher odds of actually taking their medicine versus not adhering to the regimen. And they had higher odds of having no detectable virus in the blood. We also know that compassion for patients is associated with higher quality care. And this can go in two different directions. The first is when the presence of compassion is associated with better quality. The other is when an absence of compassion is associated with lower quality of care. Let's do the former first. With the presence of compassion, many studies have shown that patients are more likely to disclose everything that's relevant in the healthcare information. Let's face it, when we're talking with patients, they're sharing some of their most private matters. And they're more likely to tell you exactly what's going on if you treat them with compassion versus not telling you what you need to know as a clinician. Also, research shows that when you treat patients with compassion, they're more likely to remember what you said. They're more likely to remember their discharge instructions. My personal opinion is that when we don't show patients that we care about them, they're not even listening to what we have to say because they believe we don't even care. An absence of compassion is seen in what we call depersonalization. I mentioned it earlier. It's part of the burnout syndrome. So it is the inability to make a personal connection. Depersonalization isn't the opposite of compassion, but with depersonalization, compassion is impossible. Depersonalization prevents compassion. Numerous studies from the Mayo Clinic and other centers have found that with depersonalization, there are higher errors, both medical errors and surgical errors. And the most common reason for these medical or surgical errors was cutting corners. So that is association rather than causation. But we see that when with more depersonalization, more errors occur. And cutting corners could be a mechanistic link between the two. We're less careful. We've probably all been associated with colleagues who seem like they don't really care, and we have observed that they're more likely to cut corners in what they do. And so those things aren't necessarily causally related, but they tend to go together with depersonalization, absence of compassion, and more medical errors. The last part I could talk to you about, but I think we'll either leave that for later or for another day, are the effects of compassion on healthcare providers. The fact that there's compelling evidence that compassion can actually be an antidote for burnout through better human connection, better relationships with patients. I actually went through that myself when I was struggling with burnout years ago. So I posed you a big question: does compassion really matter? So 1,000 scientific abstracts, 280 original science research papers behind me, I conclude, after going through all the evidence, that compassion matters for health, for healthcare, and for healthcare providers. I believe it's evidence-based medicine. I call it Compassionomics because I look at it as the convergence of the science and the art of medicine, and the science is strong. So again, I want to thank the task force. I want to thank World Health Organization, David, Ashley, Shams for the honor of being here today. Truly an honor, and I thank you very much. And I look forward to the rest of the conversation that we have in the rest of the rounds. Thank you very much.
Thank you very much, Stephen. That was fantastic. It was great to hear the scientific data behind these conclusions, and also you've stirred up quite an active chat room and questions and answers. A couple of things that I'll just mention that we may come back to in our discussion. Several commenters were wondering about the indicators for compassion, and who decides? Is it the physician, or is it the nurse, or is it the patient who decides whether they're getting compassionate care? And I know you have some things to say about that. Another question that we came in about that from Connie Demery, who said that nursing theory grounds the profession in care and compassion. What about medicine? Does medicine have a caring theory? And to that I would add, does public health, does global health have a caring theory? And maybe we can get into some of those conversations in a few minutes. I'd like to invite the three reflectors now to comment in 5 minutes or so to what some of your remarks from their individual perspectives. Our first reflector is Dr. Andrew Lakaka, who's the Director of Quality Management and Digital Health in the Ministry of Health and Population in Malawi. Dr. Lakaka spent his career developing new systems and policies to improve healthcare quality in Malawi. And so he'll be speaking to us from the perspective of a national health system and his experience with compassion and its role in quality at that level. So Dr. Lakaka, thanks so much for joining us. We look forward to your comments.
Thank you very much, and thanks colleagues, and thanks David for the welcoming remarks, and also thanks Stephen. It's been a pleasure listening to you, and all participants, Shams, who is also, yeah, great. I think to join this great presentation, great reflection on a topic that is not popular in medicine. Looking at the comments, the questions that are coming in, I've been already shaking my head. I've been trying to think about the answers. I believe that really it shows that this is a new area that has been missed for a long time. And I've been also thinking through, I recovered from COVID about 2 weeks ago. And as I was in the process, I was reflecting myself, thinking about how many people are going to our facilities and really reaching the facility physically, but not accessing the care that they went there for. So many many of us go to facilities hoping that we'll get care. We get medication, we get good doctors, we get good nurses. But how many really access what they went there for? So compassion is a big issue, it's a big area. At the national levels, I've been also thinking about this subject. Where are we missing the point? So in most of the policies that govern health systems strengthening, the inclusion of compassionate is not that, it's almost, compassionate care is marginalized. I must indicate that with the sustainable development goals, there is a patient-centeredness, patient-centered care, which is the core or heart of even quality. We can't talk about bringing services to all, leaving no one behind, when at the center of everything else is a patient. And obviously, compassionate care should be framed within the Sustainable Development Goals agenda. Guidelines at national level, likewise, they are not clear. Okay, what's the role of compassionate care? How do we reinforce compassionate care in practice? That's missing, despite being linked to the Sustainable Development Goals that I've talked about. Framework for operationalization of compassionate care in almost all countries. I've been looking for documents, policy documents, looking at the frameworks to operationalize compassionate care. They are missing. They are not available. And there comes the issue. What if you wanted to improve something, you need to measure. So how do we measure compassionate care? How do we say that this system, health system, is responsive to the real needs of people if we can't measure? Now there comes the issue about the role of training institutions. When we sit down, ask many students, most of us, why we want medicine. And I think this was a question I was asked about 20 years ago when I was being interviewed for medicine. They asked me, why medicine? And majority of patients, majority of practitioners, they always say, I want to save. I have a passion to save. Now, what comes after training school? And when we go to practice, always it's almost the opposite of what drove most of us into the training institutions. Now, what is the role of training institutions in ensuring that quality of care, compassionate care is sustainable and engulfed? So these are some areas I think that we need also to be thinking about. And when we are looking at compassionate care, the other aspect is not only from a healthcare provider. Last night I was reflecting with the scenario of COVID-19. The health system is stretched everywhere. Now you see that there are communities that are not adhering to preventive measures. Now I was saying, what is compassionate care if the community, the public is not compassionate about the providers that are supposed to provide that care? So should we talk about compassionate care only to the giver of the service rather than also to the recipient of the service? When the health services are stretched, burnout comes in. Expectations for the public becomes quite huge. How do we reinforce that compassionate care is a concept that is understood by both providers as well as our clients? Finally, let me talk about what matters more for every client that we need, every health system. In Malawi is a low income country, a resource limited country. But essentially, whenever I wake up every day, I always tend to ask myself, what matters more in the health system delivery that we are advocating for? the public. What is it if I ask anyone in the street about the health care that we are providing or that we are advocating for? What matters more? What is it that they will tell me? What one thing is it that they want to see? Maybe it could be just a smile. Maybe they will just want to see a smiling health worker. They want a listening health care worker. Maybe I may be worried about lack of resources, while that is not their main concern. So really, I think it's a pleasure reflecting on this very important topic, David. I believe that it's time that health systems at national level should start asking big questions. Compassionate can be a key to all that I think patients are looking for. Thank you very much, David.
Thank you very much, Andrew. You've given us a lot to think about, and there's certainly a large list of needs that you laid out, national guidelines, national frameworks, indicators, what to measure, training. And I really appreciate your leaving us with this question about compassionate communities and which leads into a compassionate public health. What does that mean? And a compassionate public. So thank you. That was very insightful and really appreciate your perspective. I'm sure we'll have some comments and questions for you as we move along. Our next presenter is Dr. Louis Ako Egbe, who is a district health manager in the southwest region of Cameroon. And he's responsible basically for all health activities in the Bangam district there. He's particularly interested in promoting the resilience of healthcare services to deliver quality care. And we invite Dr. Ako Egbe to speak to us from his perspective as a district health manager. Louis?
Hello, thank you very much, David. Thank you, Stephen, for that great presentation. And I want to thank Shams and the rest of the team for this opportunity to talk on this very important subject. I would want to start by answering maybe to Stephen's question, does compassion matter? Yes, and emphatically, yes. And to start my reflections, maybe just to talk on what is the district service all about, or the district health service. And I'll be talking from two perspectives as a district health manager in Cameroon, but also with my experience in Liberia at the county level, which also plays the same role as the district health service. So essentially, the district health service, translates the national health policies, into action at the health facility and the community level. But it also supports the formulation of health policies and plans, through a bottom-up approach. But notwithstanding, this is also where everything in healthcare plays out. The district level actually integrates and aligns all healthcare interventions to the national policy and goals for quality healthcare delivery. And now maybe we'll talk about quality UHC. So it all plays out at the district level. I had the experience, supporting the county, one of the counties in Liberia during the COVID outbreak, which is still ongoing. And two parallel incidences. One, a county health officer who actually led the team through the response with minimal support from the national level, but had remarkable results, in controlling the outbreak. And here I learned, later that this CHO, this county health officer, actually relates with the team in a more social, and respectable way beyond just the technical work that they do. But in the other scenario, I had encounter with another county health officer who actually made a comment that I kept reflecting that, the national level, nobody cares about us. We are here in the county fighting the outbreak. They don't care about us. And I kept reflecting. And it showed in the work that they do. You know, they were very reluctant to work because of the demotivation and many other things that came after. So how does this, you know, the district, how do they perceive compassion? First, they look at it from the national level, that the national level and the policymakers have to think about them when policies are being made, when resources are being planned and channeled, and when interventions are even being planned. At times, it doesn't even take into consideration the district realities. But also, how does compassion play out also within the district health service? So the district health manager and the team, how do they relate? You know, some district health managers would actually, you don't look into the welfare of your staff. We've talked about burnout, and especially during the COVID, this crisis, there are more burnouts even at the district level. So that is one level how they perceive it, but also from the district health service to the health facilities, which they oversee, and the communities. So I have the experience when I took over office as a district health manager to actually visit all my facilities. And when I went to some of the remote places, the challenges to even get to those health centers, it became very clear to me when you ask one of the health facility managers that your results are late, your monthly reports are late, and they tell you, oh, doctor, I'll send them next week, I'll send them tomorrow. I began understanding the difficulties that they face. But if I didn't take the time to go to some of these places, I would keep banging on them, oh, you have to send your results, your reports are late, and all that. So that is one of those are the three areas where I see how the district health service actually understands or perceives compassion. And the question, goes, how do us at the district level, how can we make compassion a reality? And I have, through my reflections, a few points to make. First, by the district management demonstrating compassion. So like I just made mention, within the team, how do you relate with them beyond just the work that you do? And from my experience in Bangam, we actually had social meetings on a monthly basis where we just relate, ask about each other's welfare, condone with those who have sad moments, rejoice with those who have, happy moments. And it actually impacted the work that we do beyond just asking for reports and getting reports and sending queries, but also the district, how can we make compassion a reality is by managing judiciously the resources that we have. Because from Stephen's reflections and paper, one of the effects or benefits of compassion is actually the cost component. It reduces cost because a lot of waste that happens at the subnational level. But I think it all plays out. They feel abandoned, maybe they feel not taken care of. So also the attitude towards work is not the right attitude. So that is one of the areas, judicious use of resources that are available at the district level. And then thirdly, how can we leverage on compassion by integrating the aspects of compassion, which Andrew rightly asked the question, the indicators. The district health services, they go out for supportive supervision. But within this supportive supervision checklist, are there indicators to actually look or, check out for compassion at the health facility level when they go to the health facilities to supervise? And fourthly, some of our health systems, like in Cameroon, we have the performance-based financing, which actually has a set of indicators to which health facilities are being rated or graded, and depending on the performance, bonuses in terms of financial bonuses are actually given to health facilities. But how can we, if we have indicators for compassion, integrate them within these performance-based financing schemes that exist in many countries in Africa now, to make sure that it actually
Louis, I think we might have lost you. Are you still?
Hello? Hello?
Very good, thanks. You're back. Please.
Oh, sorry. My network had so I was making the last point. I don't know where I stopped. Where the last point you heard from me?
You were just off for about 20 seconds or so. Yep.
Okay. So I made mention of the integrating compassion, indicators of compassion into PBF checklist. And lastly, but not the least, the district can develop strategies in collaboration with local CSOs, NGOs at the local level to actually promote compassion, at the community level and health facility level. So through this thinking and the experience in the different settings, it dawned on me that at whatever level that we find ourselves, the health system, we all need a health system that has a conscience. That is what I gathered from all of this experience in Cameroon, in Liberia. Everybody needs a health system that thinks about them beyond the technical work that they do. So I think this is a great opportunity, and I appreciate the work from Stephen and the rest of the team. Thank you.
Thank you very much, Louis. We really appreciate your perspective from the district level. As you described, that's where the policies of the national level really meet the healthcare delivery in action. And appreciate your description of the need for this relational dimension, not only in caring for patients, but also in relating to staff and in supervising and in working with our colleagues as well. Our final reflector this morning or this afternoon, depending upon where you are, is Ms. Samia Abdullah. She's a community engagement consultant based here in Clarkston, Georgia, a town sort of in the Atlanta area. Clarkston, for those of you who are not familiar with it, is known as the most diverse square mile in America. Whether that's true or not, I'm not sure, but there are people from many different nationalities who live there. And there's a remarkable health clinic there, the Clarkston Health Clinic. Ms. Abdullah is on the board of directors. She's also a current member of the DeKalb County COVID-19 task force based here in Atlanta. Samia, it's such a pleasure to welcome you to this conversation, and we'd love to hear your perspective as a community engagement person, but also as someone who's on the board of directors of the Clarkston Health Clinic. Thank you so much for being with us.
Thank you so much, David. I appreciate you. Well, nice to meet you, everybody. Thank you to Shams and to Dr. Stephen.
Samia, your volume is low. I'm sorry. We'll need.
Oh, sure.
We're just there. Very good.
Sure.
Okay, that's much better.
Yes. I want to thank everybody for inviting me to this forum. And this is really compassion in itself. Because really you see communities being at these big tables. So I really want to thank you all for giving that opportunity. Thank you, David. I really want to reflect on the word of compassion, and what Dr. Stephen said really brought a lot of things up for me. One of them is the other. And I think the seeing every person as a divine human being, walking, having a human experience. It's really amazing when you kind of look at in a human being as somebody who's with gifts and talents and life experiences in a vulnerable space. And then that vulnerability is there to bring you closer, but also give you something as a provider. So from a community space, I would like to bring in this South African disabilities kind of a chant or a motto. And this is, nothing about us without us is for us. So from a community's perspective, in a small clinic, being in the most diverse square mile of the United States, where there's a lot of nationalities, where there's a lot of communities, a lot of cultures, a lot of divine beings coming from different faiths, is how do you then see the whole human? And then not make assumptions, because sometimes Clarkson is known for diversity, but also known for a refugee resettlement, right? So when these people that coming to the clinic are not refugees. They are people that have hearts and homes. And the minute they came to the United States of America, they are citizens. And they're residents. And now they're walking into their citizenship walk, right? So language matter in healthcare, and how we call people and what assumptions it brings. And some of those can actually come with assumptions that will make the person feel as the other, like where are you from, right? And what does that bring in? So I'm saying all these things to say that a small clinic in the most diverse square mile means really working in collaboration and seeing this person as a whole, not a person that came from, a low income community, or those language that, your zip code doesn't mean your reality, right? So those things that matter, because that means that you are seeing the person and you're catering to the entire human. Sometimes a clinic, I personally had small experience I wanted to mention. And that experience is, I was coming to a meeting to the clinic, and it was, so my car punctured, or I had a flat tire right outside. And this was a very important meeting I was trying to run into. There was a gentleman who was from the Caribbean outside. And he looked at me and he said to me, "Oh, woman, your car, what happened?" I said, "I don't know, but I have to run to a meeting inside." He said, "Okay, I'm gonna fix your tire." So he stayed there fixing my tire, not knowing who I am. And at the end, by the time he entered the space to see the doctor, he said, "I'm sorry, I was fixing a lady's car outside, and she said she's one of our board members." He said immediately, he said, "I feel relieved, because I'm not just receiving free healthcare right now. I've actually gave something back. I feel I've made a form of payment to you all," right? So there's a sense of pride when people are coming to from a low-income communities, or there is a sense of receiving. And what does that make you feel, right? You are receiving. Are you receiving this from a lower end, or are you receiving this from a space that you feel that you are a contributor to the space, to the people? So I think those are small. I'm just giving this to tell you, as minorities, as people who are low income, communities that feel always demarginalized or outside of the big boxes of healthcare, there is something about equity, right? And that equity is when there is inclusion. When you see faces that look like you, that speak your language, people who understand your experiences, right? I'm from East Africa, I'm from Somalia. So imagine having a Somali, student there who's in medical school, and she's talking that language to me. There is a sense of pride. There is a sense of, I understand somebody feel what I'm feeling. So it's not the word empathy also, but it's also that I really don't have to go explain some things that I feel shame and guilt about, because I understand that other person knows this, feels that, right? Also. So I think those are very important things to understand, this idea of how do we cater to communities of color, communities that are disadvantaged, or even though I don't like using that word, there's nobody that's disadvantaged, it's just a word, right? So those wording in healthcare that makes the communities feel on the other side. So that is one thing I wanted to mention. I also wanted to mention that in this time of COVID, there is also other issues that when a person is coming in, I'll give you another example. You know, I'm East African, so storytelling is part of how I draw a picture or a scenario. There's a woman that came into the clinic and she was complaining about her feet. So she walked out of the room with bare shoes. And a friend of mine who was from the local television station, DeKalb County TV, asked me, she walked with the shoes. And then we asked the nurse, I said, what happened inside? And she said, oh, she was complaining about her feet, but then we realized her shoe size was wrong and her feet were swelling, right? So she walked away with a pair of shoes. The idea is that sometimes there are things that a whole person might need, especially in this time of COVID, right? People don't have rent. People don't have, they're still waiting for the stimulus money to be decided by the political drama we have upstairs. So all of these things that are impacting real people, there's a level of stress, there is a level of unknown trauma from communities that don't know where the next meal is coming from, right? A lot of our communities work in the chicken factories and labor work because they don't have the language skills to do high-end jobs. So when somebody walks into that, it's very important to have wraparound services, or at least not to have them, to collaborate with entities that are able to know that when you're talking to someone and you see there is a level of anxiety about them, about tomorrow, you're able to refer them to the network that will be able to offer them food assistance, rent assistance, help them with filling a form. All of those things are incorporated in the city of Clarkston networks. So therefore, the clinic doesn't work in isolation. The clinic works with that you are a small entity of a community. And you're not able to fix this entire human being. And there's nobody can fix things anyway. It's only with the God and grace of God, but then able to bring in what the whole person needs. So I say all these things to say is, how do we use, particularly today, the word not diversity, but inclusion. I would like people to describe Clarkston as inclusive, not diverse, because those are the same way of describing empathy and compassion. Those are two streams. Inclusion, diversity is just counting people. There is 60, we speak 120 languages, we're from 60 communities, but then inclusion is really how many of those providers are from those communities. How many of these nurses are from those? How many languages are spoken? Do people feel included culturally? Is there cultural competency in the space, right? So that is, for me, seeing the divine. And I'm just gonna stop there. Thank you.
Thank you so much, Samia. That was really wonderful. You've brought us back to the human element in all of the talk of compassion at these different levels. And you've helped us question or look at our assumptions. You've showed how sometimes, even if we have a compassionate impulse, we really need to have understanding that there's this potential, without taking the whole person into consideration, for compassion to maybe seep into something that's more like condescension, where someone is othered. So this idea of compassion as inclusion, I really like that, inclusion as the verb, the activity, like compassion. So thank you for reminding us of the human face, the human being within the health system. And I'd like now to turn to my colleague, Sham Syed, who will propose some questions for conversation among the four presenters. And after that, we'll open up the floor for questions. Keep those questions and comments coming in through the chat room or the question and answer stream, and we will try to get to as many of those as we can. Thank you. James, go ahead.
Yes. Really fascinating and excellent reflections and, of course, Stephen's initial presentation. Now, what we'd like to do now in the next 5 or 10 minutes is just to come to a bit of a discussion between Stephen and the three reflectors. We won't have time to delve into everything that's been said, but I wanted to turn just to a couple of points that have been mentioned by Andrew, Louis, and Samia, and then come to you, Stephen, for your thoughts on them, because clearly your presentation and the experiences that you have shared have stimulated their thinking. So Andrew very nicely described the linkages at the national level. I'd like to pick up on two particular points that he mentioned. One was on the guidelines that are developed at national level, and secondly, the training that takes place from the different training institutions. Of course, we're seeing an exchange here between somebody from that's fully familiar with the system in the United States and Andrew, who leads some of the work in Malawi. But the question to you is, based on everything that you've been able to examine over many, many years, what are the key nuggets that Andrew might take away related to development of guidelines that focus in on the excellence that you were mentioning, but bring in that compassion lens? And secondly, what might you give to us related to how training institutions could potentially bring in the compassion side? So that's from Andrew. And then from Louis, of course, many, many excellent points being made, but just picking up on two, he talked about compassionate leadership at the district level. But from your examination of healthcare organizations, and you already mentioned a couple of the examples related to compassionate leadership, if there was anything that you wanted to highlight, that would be very useful. And secondly, the use of indicators. I know that you've done some substantial work on that. And how might that help Louis and his colleagues in their efforts at the district or county level? And then turning to Samia, a very important point that she raised was related to equity. Looking at the different domains or elements of quality, thinking about how equity can be placed within looking at quality health services. Any reflections on that would be helpful. And secondly, and this is particularly something that I think you experience in your work in New Jersey, is those wider determinants of health. Samia already mentioned the linkages with food insecurity. Any reflections related to that would be helpful. We'll come to you, Stephen, just in a minute, but then just so that Andrew, Louis, and Samia can also prepare their thinking, I just wanted to turn to you after coming to Stephen to maybe mention one particular point that you have taken away from Stephen's presentation that you can action in your work at the national, subnational, and at the community level. So allow you to do a bit of thinking around that, but now coming to Stephen. Stephen.
Thank you so much, Shams. I want to thank Andrew and Louis and Samia for being the panelists today, and you've raised such important questions for everyone's consideration. First, to Andrew's point, as it relates to training and guidelines, really what we're talking about when we talk about those things are change, right? And how does change happen? And I believe that, and this will be squarely in the domain of my opinion, but I've been, after studying this for a couple of years and going through all the data, I come back to three key constructs which are important to exacting change. Number one is the evidence base. Number two is around time. And number three is around the concept that change is possible, that compassionate behaviors can, in fact, be learned. So number one, under the evidence base, I already spoke to, I just gave you a synopsis some of the available data that more compassionate healthcare is associated with better outcomes for patients across physiological, psychological, self-care, and quality of care domains. And so once you see the evidence base, I think it's hard to just consider compassion to be a nice to have. Rather, I think you begin to think, as I now think of it, as a cornerstone of quality care. So I believe that after looking at the evidence base, that compassion is part of high quality healthcare. And if you don't have compassion, you don't have high quality healthcare. You might have some proficient technical care, but you don't have the totality of care. And actually patients will tell you that. So there are a number of studies from the patient perspective which show quite clearly that when care has more empathy and they're treated with more compassion, they believe that they're being treated with higher quality healthcare. They believe that the quality of care is better. And I always think it's because even if a patient doesn't have a healthcare background and you're treated without compassion, they're going to think, well, if you don't even know the basics that you're supposed to treat me with compassion, how do I know that you know how to read that, interpret that test result? How do I know that you know how to read that EKG or interpret that chest X-ray? How do I know that you know how to do all the basics of the technical part of care? And so there is an evidence base for quality, and we have to accept that if we really want change to occur. If we just believe it's a nice to have, like a dessert in addition to an entree, as my colleague and co-author Anthony Mazzarelli says, if we just believe it's that, that's not really going to change people's behavior. Number two is important, and it's about time. So how much time does it take to treat people with compassion, treat patients with compassion? And this is important because if your clinics, your hospitals are as busy as mine are, people often believe that they don't have time to treat people with compassion. In fact, there was a study from Harvard Medical School published in the Journal of General Internal Medicine back in 2012, which surveyed physicians. They were resident physicians, and 56% of those physicians said that they don't have time to treat people with compassion. Think of that. That's a staggering number, in my opinion, that more than half believe they don't have time. Well, it begs the question, how much time does it actually take? So in going through all the data, we found 6 different studies that actually timed it. And what they found, in every case, it was less than a minute, and usually it was about 40 seconds for a meaningful compassion connection. Now, that's when it was measured in the confines of a clinical study with some rigor. That's how much it may feel longer, but that's actually how much time it takes to communicate compassion to another person if you actually timed it. Now, some people actually go the other direction and bristle at what I just said because they believe it doesn't take any time at all. You can go through your day with the same brusque efficiency, letting everybody know just how busy you are, or you can treat every person you meet with compassion, and the reality is it won't take you any longer than it did to treat people with brusque efficiency. And so number 2 is that it really doesn't take time. People just think it takes time. And in fact, a psychology study from the Wharton School at the University of Pennsylvania found that the only way we feel time affluency, meaning we feel like we have enough time and we're not in a rush, is when we treat other people with compassion. When we donate time to other people, we give time to other people, that's when we feel differently about the time that we have, and we don't feel like we're in a hurry. So there's quite a bit of data around that. So number 1 was realizing there's an evidence base. Number 2 is realizing it doesn't really take much time at all. And number 3 is realizing that change is possible. I used to believe that people were either hardwired for compassion or they were not. When you go to the data, that's not actually true. My colleagues and I completed a systematic review and published it last year in PLOS ONE. And we found that specifically for physicians or physicians in training, there have been 75 studies in history that have tried to teach compassion to young physicians or physicians in practice. And 3/4 of those found that it actually improved compassionate behaviors to some extent that was measurable, often from the patient perspective. So compassion training actually works because what you're trying to change is behavior. You're not trying to change what people believe in their head necessarily, but how do you interact with other people? And so change is possible. Outside of the healthcare domain, there are numerous studies in psychology and psychology science that have shown quite clearly that compassionate behaviors can in fact be learned. So the three things: that realize there's an evidence base. Number two is realize it doesn't take as much time as you think. And number three, realize that change is possible. However, here's the key: you have to want to. You have to want to. So there's an investigator named Carol Dweck from Stanford University who wrote the book Mindset a few years back, and it's become a centerpiece to a lot of discussion around education in the U.S. for sure, but also more broadly. And you have to have the mindset that you actually can get better, that it's not compassion is not a trait, it's actually a skill. If you believe, the evidence shows, and her laboratory has shown, that if you believe it's a skill and you can get better at it, you will. But if you believe it's a trait that people either have or they don't, you won't put in the time to get better at it, and you won't. So change is possible, but only if you want to. Moving on to Louis' comment about indicators. My colleagues and I published a brief 5-item compassion measure. We published that last year in JAMA Network Open. That is open access, so anybody can get to it across the globe. It's 5 simple questions it measures it from the patient perspective. Was I treated with compassion? That question came up earlier in the rounds, where whose perspective is it? Is it from the patient, from the healthcare provider? I will tell you that I personally don't put a lot of value in what a physician, for example, thinks of their own behavior, because there's a plethora of data to show that physicians specifically often have blind spots, that they believe they're very compassionate, but the patient is not really experiencing that at all. And so what I'm interested in is from the patient perspective, and that's why our measure uses the patient perspective, and that's what we put the most value in. In terms of Louis' comments about leadership, there are a number of studies that show that when there are compassion practices in a healthcare environment, specifically in a hospital environment, meaning recognizing people when they're going through difficult times, recognizing people for their compassion, and celebrating people who have exceptional compassion, that patient experience actually gets better. And so I think that having compassion in leadership to treat frontline healthcare workers is vitally important. I was really touched by Samia's comments regarding equity and inclusion, but really about humanity. And that was something I didn't say, but I should have. All over the world, perhaps, but especially here in the U.S., we are currently in a brutal confluence of injustices. So we are in the midst of a coronavirus pandemic, which is killing people of color, afflicting and killing people of color disproportionately to what white people are experiencing with coronavirus. We're also in the midst of the witnessing of the killing of George Floyd in the U.S., which was an amazing, it has set off much discussion and much unrest in the U.S., as it should have, because of how appalling it was. This brutal confluence of injustices makes me recognize that while I was talking about compassion and about empathy, and that empathy is really a precursor for compassion, because you have to sense and detect and feel someone's pain and suffering if you're going to respond to it with action, there's also a precursor for empathy. So empathy is a precursor for compassion, but there's a precursor for empathy, and the precursor for empathy is fully seeing another person's humanity. And if you don't fully see somebody's humanity, empathy will fail and compassion will fail. As a white person, I don't know what it feels like to experience having my humanity go unseen. And I can only imagine what it feels like to have your humanity, see indifference to your humanity through the disparities that we have and structural racism. And you could say that all healthcare disparities, all of them, whether it's lack of access to healthcare or all of the disparities, whether it's disparities in outcome, that somehow they're rooted in a lack of empathy for people who in health disparity populations. But I also wonder what people are experiencing at the personal level, not at the systems level, because of what we know about implicit bias and how pervasive that is. So I think what Samia said about seeing people's full humanity is really necessary before we even get into everything else about compassion. So I just want to thank all of our panelists, Andrew, Louie, and Samia, for these wonderful insights.
Stephen, thank you very much. Just like to turn to Andrew, Louie, and Samia. This is, of course, the whole idea of a Global Health Compassion Round is to share and challenge our thinking and spark new thinking. But if you could, just one key lesson, one key piece from this discussion with Stephen that you were going to take home with you with your work at the national level, Andrew.
Yeah, thank you very much, Stephen. Thank you for the key without compassionate care. That's a key word. Quality is meaningless without compassionate care. Thank you.
Thank you, Andrew. Louie, one final point from you in terms of anything that you took away from this discussion that you will then apply at the subnational level?
Yeah, thank you very much, Shams. Thank you very much, Stephen. So one take-home message for me would be the fact that the caregiver, when you give out compassion, it benefits you more, and that is to go to the point of burnout. So those of us working in some of the very difficult, hard-to-reach places in our countries, as a health facilitator, district manager, when you give out compassion, you show compassion to your collaborators, I think you reap the benefits, particularly at this time of COVID-19 outbreak, where all of us are stretched out. I think it's the way to go, relating compassionately with your collaborators, with your health facility managers, and those you work with. Thank you.
Thank you, Louie. Turning to Samia before turning back to David.
Yes, my reflection is that continue to advocate against all the injustice, systematic injustice that is built in healthcare access for people of minorities and color. And I really experienced that myself coming from East Africa, Somalia, that I have to justify that I'm Black, because I am an immigrant, or I'm not going to use the word refugee, but am I really Black? And what is my advocacy for Black sisters and brothers? So that continuous advocacy for access to healthcare, not only access to healthcare, but access to wraparound services, particularly in COVID time for minorities and color, because COVID is Black and COVID is hitting our minority communities larger than any other communities.
Thank you, Samia. Fascinating discussion. Of course, it could go on for much, much longer in terms of this panel discussion, but I'm going to turn back to David to close us out with some questions that have emerged from the chat box, and of course, closing it out for the compassion rounds as a whole. David.
Thank you very much, Shams, and thank you for all the speakers for those very thought-provoking comments, and also to the participants who have sent in such fascinating and really profound questions. I wish we had another couple of hours to really dig into them. They range across the board from issues of the relationship between compassion and trust. Sami is just focusing just now on this relationship of compassion and justice. How do we influence donors and the people who make healthcare decisions about the necessity for compassion? Some more discussion about the indicators, particularly when we get to the systems level. How should Louis measure compassion in his health workers or in the healthcare system? There's clearly a need for better measures there. I would like to spend the last 4 minutes of our time together, rather than digging into just one of these, before I summarize, I'd like to ask each of the presenters if you could tell us what sustains you in your effort to be a compassionate person, a compassionate healthcare provider. And if this is too personal a question, you can decline to answer. But I think we've heard from each of you, you each have a specific, obvious compassionate impulse, and you're engaged in compassionate work in the systems in which you live and work. So if we could start with you, Andrew, what keeps you working towards being compassionate? What sustains you?
Yeah, I think, thank you very much, David. That's a very personal and important question. Religion has a big bearing on my side. I think since the time I thought of going to medical school, I think that passion to serve has been, I think, the motivator. So I would put religion as one of the influencer to compassionate care. Thank you.
Thank you very much. Louis, can I turn to you with the same question?
Yes, thank you very much, David. So for me, I think it's the fact that I've been a victim of a system which is not as compassionate as it should be, and so there's a burning desire to change that within the sphere that I operate. So I think that is a driving force. Thank you.
Thank you very much. Samia, if you could address that question, please.
Yes, I think what sustains me is a personal space. My mother, who was a Sufi, and I remember when I was young, maybe 13 years old, I lived in Saudi Arabia, and then we went to Egypt for a holiday, and we're outside the mosque of Prophet's daughter Zainab, and then my mother was outside. My father then sent money, a monthly expense. We came out from the mosque and my mother was outside, but the children, all her body was full of jasmine necklaces. And we said to her, Mommy, where did you get all these jasmine necklaces? So the children jumping on the street sides, and those were the street children who were beggars. And then my mother said, I gave all your money to them. And I bought all their necklaces. So now you go and step in their shoes. Sell this to get a ride home. So I've learned how to be in that other space.
Thank you very much. And Stephen, can I ask you that question? What sustains you in your work and in this?
What sustains me are relationships. And so what we found is, in going through the data, that if burnout and resilience are a continuum from one side to the other, that one of the biggest contributors to resilience under pressure and stress are our relationships. And sometimes it's relationships with patients, sometimes it's relationships with colleagues. relationships with my nurses in the ICU during COVID have been very important to me, because many of my patients can't talk. They're on a ventilator. They have a breathing tube in their throat. But I can have relationships with the nurses, and we can experience this and go through this together. Relationships with people, your loved ones, matter deeply. But I believe that in general, not just in healthcare, that the primary or the foundation for resilience are relationships. Yeah.
Thank you very much. And I thank all of you for being willing to respond to such a personal question. This was not, I didn't give you any warning this, so I appreciate your sharing that with us. I think all of what you've said is so important. We do need to be sustained in this work. The quality of the relationships we have are so essential to that. For many of us, a religious faith and orientation is also, which is embedded in relationships, is very important in sustaining the compassionate work that we want to do. I apologize that we don't have time to go into some of the really key questions that have come in. Once again, we've underestimated the time it would take to completely unpack some of these questions. I will say that there will be a report of this webinar. The webinar will be available to be seen by you and your colleagues as well online. In the report, we will include some links to some of the articles that have been mentioned, including those on measuring compassion that Dr. Trzeciak and his colleagues have done, as well. If it's okay, Stephen, we'd like to also point a link to the study that you did on the efficacy of training compassion in healthcare.
Sure.
And that would be, we would love to share that. We hope that some of the questions have been answered in this last 20 minutes, some of the questions that have come in. We will take on board all your questions. We invite those of you who feel that your questions were not addressed, if you'd like to contact us here at FACE, please do so. And we really thank you for your participation. Shams, in closing, are there any words that you would like to say?
Just a big thank you to everybody that's given up their time to be with us. We know how busy colleagues are, and really a fascinating and important discussion. As I said in the beginning, we do know a few things about compassion, but there are many things that we don't know. So it's exactly these types of explorations that we need to unpack and think through together how we're going to have compassion as a core element of quality health services across the world. So thank you, David, and thank you, everybody.
Thank you, Shams. And I just want to say, many of the questions that have come in, there is some ongoing work. For example, looking at indicators. There's some work looking at some of these issues of training. And the purpose of our time together is to sort of share the information as it comes in, to encourage and challenge each other. We will try to post new information as it comes in on the website and to keep each other apprised. But I'd like to thank especially Stephen, Andrew, Louis, Samia for your wonderful contributions today. Shams, you and your team for co-hosting this, and for all of the participants and all of you who've tuned in to us today. Big thanks to all of you. Take care and be well.